2016 was when we peaked. By October 21st of 2016, we had 251 overdoses. So that's almost 100 more than where we are today. And, you know, as I say all the time, we use the numbers because we have to calculate where we are and how we're doing. But doing this, never losing sight of what's behind those numbers. So that's almost 100 people fewer who experienced an overdose, multiplied by the family and friends of all those people. So you're talking probably close to 1,000 immediate people that did not suffer that loss. And that's, you know, there's so much bad news. That is something to be reflecting on, is what we, and when you contrast that with the rest of the state, it's clear that what's making the difference here, we aren't protected in any way. What's making the difference is the partnerships and the work that we're doing. 2017 is when we started to see our numbers go down, and that went down to 222. So from 251 to 222. By 2017, I'm sorry, that was 17. 2018, we were at 195, continuing that drop. Last year, we're at 184, and this year, 146. So again, almost 40 fewer from last year to this year through what we've all experienced over the last 8 months, which is really fairly amazing. Since that time, we've had 14 other overdoses across the county. They have happened in Framingham, Malden, Medford, Wakefield, Westford, and Woburn. So that's where we are with the overdose piece. Equally concerning, and you know, again, people have been with us for a bit. I've been talking about this for over a year now, before the pandemic began. And in talking with the experts, obviously we are very careful in phrasing this, but we have seen a pretty startling increase in the number of suicides across our county. And we have had, since we last met, we've had 13 suicides across Middlesex County. That is a startling number. And when you delve a little bit into the facts of them, they're even more concerning because they have been truly every demographic. Men and increasingly women, particularly, you know, we were talking a few moments ago while we're getting ready about the fact that because we have such strict gun laws in Massachusetts, that does reduce the number of firearms that are out and about to some extent, and the number of firearms that we see by suicides we see by firearm. The vast majority of our suicides in the last couple of years are hangings. You virtually never saw women hanging themselves. That has changed pretty dramatically. And the range of age from teenagers to pretty old folks who are that we saw commit suicide over this past year. So that's very concerning. When we are grateful that our partnerships with clinicians have been growing, and we're really looking at developing the strategies for that response. And I want to call your attention to one of the very valuable resources we have that was written by Franklin Cook, one of our partners at SAD-OD, that's available through the Department of Public Health on the MassGov website. And it was originally designed, it's a resource that was originally designed for folks on the front line and how to help them deal with what they were seeing in responding to overdose deaths. And there are lots of tools and resources to help support folks that are on the front lines and how to incorporate strategies, coping mechanisms, and the way that we really should be building support systems for people. So I want to talk about one other thing which really informed our choice of presenters today. Many of you might have seen just before Halloween on October 28th in Philadelphia, Walter Wallace Jr., 27 years old. His family had called the police because he was in the midst of a mental health crisis. That situation did not go well, and Mr. Wallace ended up being shot by one of the responding police officers. And we've heard a lot of talk about the response as part of police reform to emergency calls, you know, when separating out those that are really like with Mr. Wallace, behavioral health issues and how we can respond better. Just the other day, Mayor de Blasio in New York announced a new mental health team of emergency medical workers that will be going with every 911 call in 2 high-need communities in New York. And starting in February of 21, these new teams will have both physical and mental health expertise and experience in crisis management and de-escalation. And the hope is this will reduce the number of times that the police will need to get involved on that. And that model is built on a successful alternative developed in Eugene, Oregon. That program is called the CAHOOTS program, standing for Crisis Assistance Helping Out on the Streets. It's really embedded in their 911 system, and paramedics and crisis workers go out as an alternative in non-violent situations to the police. And last year, that team responded to about 24,000 calls. And in only about 150 of those, so probably only about 4 or 5% of those calls did they need to call for police backup. And really, there's a lot of cities doing that across the country: Albuquerque, Denver, LA, and San Francisco. Boston in 2011 established a program between, excuse me, Boston PD and the Emergency Medical Services Team, which they call BEST. It's based out of Boston Medical Center. And it's the same idea. Clinicians go out, they try to stabilize nonviolent situations where the person has a psychiatric emergency. And in September, Boston added 15 more social workers. And interestingly, you may remember there's been a lot of talk about the Boston police overtime budget, and they were able to really drill down on their overtime, reduce their overtime, and they used that saved money on overtime to fund those 15 extra social workers that have joined them. We have similar programs here in Middlesex. There are co-response teams in lots of our communities. Advocates, Inc. operates a pre-arrest co-response program. Same idea, that clinicians sometimes are less threatening to the person in the psychiatric situation. They're able to diffuse the situation. Framingham has had a model of this since 2003, Marlborough, Watertown, and Natick, as well as a host of our other communities: Ashland, Sherborne, Holliston, Hopkinton, Hudson, and Sudbury, have developed these models. And today we're going to be talking about a lot of these different models. There's no real one size fits all. There are lots of complexities and lots of opportunities. You know, many of you may have seen over the last week, we had 3 situations that resulted in police officers having to use their guns in response. One of those was fatal, 2 were not. In every one of those, there were underlying mental health issues. In every one of those, there were used the things that these models incorporate. There was response by clinicians. There were use of non-lethal force, beanbag, force to subdue the individual. These were people with experiencing very severe mental health symptoms, presenting a grave danger, armed, and ultimately the use of force was necessary to resolve them. So that is the balance that we're always trying to strike. In one of those situations, the clinicians responded in consultation with the family. There was an assessment made that it would be better for the person. He would overreact if he saw the police. So clinicians responded. The individual went from relative calm to great agitation pretty quickly, and produced a gun, causing obviously the clinicians to rapidly leave and requiring the police to go in and respond. So that's, you know, part of the balance that we are always striking: the public safety versus dealing with these situations. And unfortunately, even with the best of resources, and we really saw that on display here last week, the situation often de-escalates for a period and may escalate again pretty quickly, putting people in situations of making decisions really in a split-second mode. So as we listen today and talk about some of the models we have going on, just keep in mind all of the complexities of this. So our first presenter today is Matthew Page Shelton. And some of you may have heard from Matt at an earlier meeting. We're so grateful when people are willing to come back and help us. Matt's the regional director of the Frontline Initiative. That is another police mental health collaboration. He's based in Tewksbury. And the Frontline was begun in 2016. It's a regional collaborative to help those communities access a full range of services and programs. And it's available for folks in Chelmsford, Billerica, Dracut, Tewksbury, and Tingsboro. It provides a direct connection to a holistic trauma-informed behavioral health and substance use services. It also gives the communities resources for prevention, crisis response, and recovery. So we're so happy to have you back with us. Thank you.
Thank you, DA Ryan. I am going to just pull up a little PowerPoint here. And for those of you who were able to attend the previous discussion about the Frontline Initiative, some of this may be a little bit repetitive, but we've attempted to sort of update it a little bit. But I wanted to take this opportunity to talk about what the Frontline Initiative is, but also in the context of sort of what the DA is talking about is sort of what are these different types of programs and how does the Frontline operate in sort of that model. And so the Frontline Initiative is a regional police mental health collaborative. As the DA mentioned, we serve the surrounding towns around the city of Lowell. Tewksbury, Billerica, Chelmsford, Dracut, and Tingsboro is our newest addition to this group. They added this year in 2020 as a part of an expansion program. Our commitment is to serve the communities, provide them direct connection to behavioral health and substance use services in a whole person, trauma-informed way. We sort of base ourselves off of a recovery-oriented, trauma-informed program. Our focus is on making sure that we're meeting the client's needs and reducing the opportunities for engagement with the criminal justice system. So the partnership began between the four communities in 2016, the concept being that they saw sort of this new model that was happening in other parts of the nation, where the use of crisis intervention teams were becoming popular, and also the state of Massachusetts was also interested in the concept of co-response. And so these four communities decided to come together, having like demographics, and to participate in a co-response program hybrid with the Department of Mental Health. So in 2016, they forged a partnership with then Leahy Behavioral Health, now Beth Israel Leahy Health, in order to provide embedded master's level crisis clinicians that could be used in co-response. In 2016, 2017, they received funding from the state to embed the clinician. And in 2018, we were able to begin launching a data-driven co-response across all of our communities. In 2019, we were very lucky to receive expansion funding through the Department of Justice, Bureau of Justice Assistance, and that is now allowing us to add a second full-time clinician as well as a certified peer specialist to our community. And in 2020, we were able to form an interagency task force, which is a part of the Police Mental Health Collaborative. We added, as I mentioned, the town of Tingsboro, and then the role of regional director was created for the capacity of running this regional Police Mental Health Collaborative. So our clinical staff is made up of a prevention program manager, which is Maria Rogerio. We have our co-response clinician, Caitlin Bell, who's brought to us through the Lowell Crisis Team. Kate Bergeron is currently serving as our program's grant coordinator. And then we have a collection of clinical interns who work with us, from social work students to those training to become licensed alcohol and drug counselors. And we are able to utilize these additional sort of supports to fill in the additional high-level needs, especially as we're seeing increases in calls for service during the pandemic. We are also very proud to have our law enforcement staff who support the work. We have CIT Officer Welch from the town of Tewksbury, CIT Officer O'Keefe from Tewksbury as well, our CIT Lieutenant Hearn from Chelmsford, CIT Officer Bushnell from Dracut. We also have our command staff with Deputy Roy Frost from Billerica, Deputy Sean Woods from Kingsborough, and Deputy John Bodo from Tewksbury. And all 5 police departments, their chiefs sit on the Interagency Task Force Leadership Team, who help to guide and make decisions as we move forward in making decisions regarding how police respond to those who are in mental health and substance use crisis. So we provide a bevy of services. I won't go into all of them. We've talked about these before, but if anybody has any questions, feel free to ask. But we sort of break them into 3 major tiers. We focus on prevention, with the main goal being preventing and supplying the community with information psychoeducation in order to prevent a crisis from happening or to prevent a criminal justice involvement or law enforcement involvement from happening. And so this can look in a bunch of different ways. Typically, it works with our youth. It's focused on substance use and focusing on drugs of first use. With adults, we're more specifically interested in assisting with what we consider social determinants of health, right? Are folks struggling with housing? Are they struggling with food insecurity? Are they struggling with access to care? And so we can sort of step in a preventative way in order to prevent something from boiling up into a crisis. However, if it does, and we do have calls for service for those struggling with mental health and substance use challenges, then we're able to use our crisis response with our master's level clinicians, as well as providing a bevy of services through our internship program. And then finally, the 3rd tier is our recovery support focus, which focuses on serving those who are in recovery from substance use and mental health challenges so that they can remain healthy in the community and live a fulfilling life. And so, again, with the goal of sort of maintaining and minimizing the engagement of law enforcement and only utilizing law enforcement when absolutely necessary during a crisis. So when we look at what are the types of training that officers are receiving in our area, Tewksbury, Billerica, Chelmsford, Dracut, and Kingsborough are all signed on to the One Mind campaign, which is through the International Association of Police Chiefs. The One Mind campaign requires that 100% of all sworn and non-sworn staff must go through mental health first aid, which is created through the National Council on Behavioral Health. And that's an 8-hour certification course that provides a basic understanding of how to respond to people in mental health and substance use challenges. That is instructed by multiple instructors. I am a certified instructor and often will lead that training. And that training actually just went through a massive rewrite, which has really been beneficial for helping our officers understand how to respond to calls. The second part of the One Mind campaign is that they're expected to train 20% of their officers and staff in crisis intervention training. And this is a 40-hour certification course that delves much deeper into the work of responding to mental health and substance use challenges and how to de-escalate a crisis if they respond to a crisis. This is a training that we are very lucky through our expansion funding with the Department of Justice. We actually are in the planning phase right now of bringing a 40-hour CIT training here to the Greater Lowell region, and we'll be able to help support not only our departments, but the departments throughout the Greater Lowell region or Northern Middlesex area with CIT training in the coming months ahead. And then furthermore, we look at constant opportunities, especially under our expansion funding with the Department of Justice, to provide internal training focused around cultural competency, racial equity, trauma-informed care, gender-responsive work, and motivational interviewing for police officers. And all of this is in an effort so that there's this constant sharing of information between both sides. This is a learning experience not only for the clinicians who are getting the opportunity to be embedded in a law enforcement environment, but it's also an opportunity for the law enforcement partners to be able to train and learn from the clinical team so that everybody has a better understanding of what the other is doing and able to respond in an equally appropriate way. So I just wanted to sort of share, when we talk about like what does it mean to be in co-response, what does it mean to do this work, and why is it so important? It's so important because when we look at data, which tells the story, and we look back since 2018 with the Frontline Initiative, we've had over nearly 3,500 referrals for co-response outreach, and that has, through that work, we've been able to divert a little over 820 emergency rooms visits. We've been able to divert 461 criminal charges, and instead get people the appropriate help that they need for their mental health or substance use challenge. And you know, these diversions come with a cost savings to the taxpayer, especially if those folks are on public benefits. And so, you know, right now we measure that through numbers that are provided through the Department of Mental Health, and you know, we're able to say that we can estimate that about $4.5 million has been saved through that work. And when we look at the calls for service, 80% of those that involve mental health and substance use are non-criminal in nature. And so that shows you the overwhelming need for access to clinicians in co-response with police, because 80% of these do not necessarily need to involve a law enforcement response. And of the remaining 20%, 14% of that of those calls did not end up resulting in a criminal charge, and instead were diverted, and we were able to provide instead appropriate levels of care. And within only 6% of those were charges actually brought forward. And so, you know, we're able to say that 70% of cases where charges were possible ended up with the person served receiving the appropriate mental health or substance use care over the course of the work that we've been doing. So I just wanted to sort of highlight the need for law enforcement and behavioral health integration. So in recent events in cities across the nation, we have shown a light on the continued need for improvements in racial equity in law enforcement, and we continue to have these discussions each and every day. Additionally, there is a need for improvements on how society handles mental health and substance use challenges in the community. Law enforcement is the first to tell you. I know when I first got on the job here some years ago, one of the officers said to me, you know, I never thought when I took this job that I would be a clinician, and I'm so glad you're here, because now this is going to sort of shift some of that off of us. And you know, this is not something that they had in mind when they stepped into this role, but yet the focus has been given to them, the charge rather has been given to them to sort of manage these calls in the community. And so, you know, we're always looking for, is this the best way? Is there a better way to do business, and how do we do that? You know, and then we are beginning to see a trend right now. I've been having conversations with several of my colleagues across the state, and we're beginning to see a trend where many behavioral health partners are attempting to lean out of partnerships with law enforcement, especially in the areas of co-response and jail diversion. And this is sort of a troublesome trend that we're beginning to see, is that there's this sort of stand back mentality from behavioral health providers because of not wanting to be seen in relationship with law enforcement. And we would argue, especially from my position, I would argue this is the moment as behavioral health providers we lean in, not lean out, because this is really the moment where we can step in and work with communities to make the response to behavioral health, to mental health and substance use calls stronger, and support our law enforcement partners. Some questions that we work on, as I was pondering this, these are some questions that we talk about here in the department and as a region. What is the role of police in behavioral health calls for service? How do we incorporate behavioral health community partners into the work with law enforcement? And how do we provide more community support to prevent crisis level events? These are things that we are constantly working on. Anytime we're looking at program expansion, or additional grant opportunities to bring additional programming to the communities. These are the questions we go to because, you know, we want to minimize the amount of times that families feel the need to call in to law enforcement for a law enforcement response. We would rather have them reach out to us or utilize programming that's available through the behavioral health unit so that they're not having to go through law enforcement. And steps that we're taking, so we, obviously the inclusion of master's level clinicians to respond in co-response with police. Other things that we attempt to do is, whenever possible, we look to have the clinician respond with a plainclothes officer in street clothes, with no uniform, no lights and sirens, in an unmarked vehicle. Again, lowering the stress level, being able to help de-escalate the scene before even arriving. Or we have conversations with the clients, in advance, or family members in advance, to say, are there things that that work for this person when they're in a crisis? What sort of treatment would they prefer? How would they like the response to look? And so that we're able to better identify and then keep notes on those for future events if necessary. Prevention support, again, for youth and adults is so important. Recovery services to aid those in recovery from crisis. It's important to provide psychoeducation for the community as well as the officers, because often what we find is the reason why they're calling 911 is because they didn't know where else to go or who else to call. And so by educating them on the resources that are available in the community, educating them on the resources available here in the departments, that they're able to better utilize those resources in the future as opposed to calling 911. And then work with our law enforcement partners to decriminalize those struggling with mental health and substance use challenges, so that we can make sure that all of those who need to be receiving the appropriate level of care, as opposed to being locked in prison, are getting to that outcome. And I'll wrap up by just saying, we have a community line that's available 24 hours a day, 7 days a week. The community can utilize to get a hold of resources. I am at the disposal of anybody who's got questions or would just like to talk. I give our contact information there, and we're on social media, and we try to get out the word through social media as much as we can to be able to share and provide access to resources and information and support the community in any way we can. So with that, thank you all very much.
Thank you, Matt. Anybody have any questions? Anybody have any questions? And either raise your hand for real or put it in the chat.
This is Nora. Of course, I have a question because it's how I roll. Matt, the training module, the 8-hour mental health first aid, is that available generally? And this may be something that other folks know about, but it just, is that something that other folks can take advantage of?
What was that? I'm sorry.
The training program, the 8-hour mandatory mental health first aid program.
Yes, yep. That is a nationally available model. It's offered through the National Behavioral Health Council, and there are different modules. So we use the public safety module with officers. There's also one for specific for firefighters and EMS, and then one also available for the general public that we use. I recently actually just did a course for, I think it was the Lowell Public Library and Middlesex Community College Library, because they were seeing an uptick. We've done it for libraries, we do it for general public. Pre-COVID, we were doing it for the community at large, but it is something where members of the community can be trained as mental health first aiders and be able to have the skills to be able to intervene in a mental health crisis and provide initial support.
And I see people are putting in the chat places where the training's available that might be, well, not that we go geography anywhere, but they do provide geographic opportunities.
Yeah, we have an upcoming one in 2 weeks at Lowell House. I believe I still have some spots left, and we do it throughout the year. And I'm always looking for a co-trainer and can be a co-trainer, although having two Matts might be confusing.
Bill Gard, did you have a question?
Yeah, this is kind of tag team Lowell House. Matthew, I'm kind of curious. We have a lot of really extensive providers that provide substance use and mental health services in the greater Lowell community. How do you coordinate with those providers? Because this is great stuff, and I'm hearing it actually for the second time, but we certainly would like to hear more about it.
So what we often offer is, as we get introduced or meet with community partners, we ask them to or invite them to join us for the interagency task force meeting, which happens quarterly. And that's an opportunity to get all of the community providers together along with the law enforcement partners to discuss what's going on in the area. We recently added, the Department of Mental Health has been an active participant for years, but then we just recently added the Department of Developmental Services, because we found that our community with intellectual and developmental disabilities were underserved and were not receiving a voice at the table. And so that was an opportunity to give a voice to that portion of the population. And so I would say reach out. We would love to have you. We love to add anybody we can to the meeting, especially in this virtual era that we're in. We send out the Zoom link and everybody's welcome to join.
We'll be reaching. Thank you, Matthew.
I just want to point out, does everybody see that Bill has his camera positioned to give the best view of his new space? Not so new now, but it feels new because we haven't been there.
And I'm also blocking poor Nicole in the background that people frequently say, what is that woman doing back there staring at us? So,
but you never know.
Lovely cafe, as Marion is saying.
And Matt, somebody's, Mike Hugo's asking,
come in.
Can we share those slides that you use? Yeah. Okay, great. Any other questions? All right. Matt, thank you. Thank you. And next up, we have Marianne Manzi, who Marianne's been at Lowell PD since 2007 and does sort of a host of amazing things for them. She's currently serving as the Public Safety Research and Planning Director. She and her team have been working with UMass Lowell and the command staff at Lowell PD to build a justice and mental health program that will suit the needs of the Lowell Police Department and the community. And they've begun to implement that multi-pronged approach to address community and police needs. And, Lowell's done among so many of our departments, and they're so different. People have really been creative about how they're looking at what their city or town needs and developing that program. So Marianne, thank you so much for being with us.
Thank you very much, DA Ryan. I appreciate the opportunity, and it's going to be hard to follow Matthew. I'll have to say that. He's doing a great job with this collaborative currently. And for the LPD, this has been a journey for us. It's definitely been a journey for the past 3 years that we've been in the planning process of putting together a justice and mental health program that would work for the police department and the community themselves. We researched the different models, the CIT and the co-responder program and mobile crisis teams, and worked with UMass Lowell and the command staff members to really narrow down what would work for us. Additionally, in early 2019, along with the Massachusetts courts, they helped coordinate a community justice workshop to do the, I just drew a blank on the name of it's the intercept model, sorry, to really see, and that was actually with DA Ryan and Judge Forts and a host of social service providers, a lot of on this call right now, to really look at all the intercepts of our justice and mental health calls and see what would work for various areas. And one of which, like, our big takeaways for the police department were, we needed additional training was definitely one of the top priorities, as well as a co-responder implementing a co-responder program. We did receive funding to implement these ideas and trainings in late 2019, and we have started similar to what Matthew was saying to the One Mind campaign. We're definitely not there yet, but we are working towards getting all of our officers, sworn and civilian personnel, on mental health first aid. We started implementing it in the academy a couple of years ago. And we're working towards getting at least 20% of our force trained in CIT. I think right now we have 19 sworn members trained in CIT, a mix of both officers, detectives, and supervisors, which is great for us. But it's gonna, if we're talking 20%, we need 50 at least trained. And our trainings and a lot of our programs kind of took a bump. Well, we hit several bumps in the road in 2020, especially in regards to our co-responder program, but we are getting through those. And we are modeling the co-responder program after Advocates Inc., which DA Ryan mentioned earlier. They started in Framingham. And when Superintendent Richardson and myself and advocates met in Lowell District Court probably over a year ago now, hearing, how they started. And I think the deputy at the time in Framingham, I believe now is actually the chief, was also there and explained the process with to the chief, and the chief was completely sold and wanted, definitely wanted to implement using the advocates model, which was it's very deliberate in their hiring process, especially, making sure that the clinicians are going to be compatible in a police department. It's really a 4-step process in the hiring, and the last step is actually a ride along with police, just to ensure that this is the right clinician for the position. Because sometimes you get through all the interviews, but then you get into, and this is what advocates has experienced in the past, you get to the ride along, and it's not for everybody. So that's an important piece of the interview as well. But we're on a good path now, and we're hoping to have clinicians on board in 2021. I mean, if we could, we would have had them on board years ago. This has definitely been a process and a deliberate process for us at the police department, just to ensure that we're doing this the right way and with the right partners. And we only have one chance to really launch this co-responder program, and we understand that if we get off on the wrong foot, it really could ruin it for the department and the community. So we want to make sure that we're doing it diligently and planning everything out. But we're really hoping in 2021 we've got the clinicians on board corresponding with officers, because the chief understands the need. We all understand the need, and obviously if the chief had his way too, we'd have them already on board. It's unfortunate that we don't yet. But one thing I do want to mention too is that and everyone on this call understands this, but this kind of highlights, there was the chief received a call from a community member. This was probably about 6 months ago now, thanking the chief for the police department's response to a call of himself. He was calling, he was in mental health distress. He was having a really bad day, and he did not want to, he was done. He did not want to go on. However, the officer's response and how they handled the calls, they, everything was able to be resolved with no violence, thank goodness. And the person was able to get his job back and move on from there. And he just wanted to call and let the chief know this and show his appreciation to, the officer's response to that. So it just highlights the importance of what we're trying to do here and what our surrounding communities are doing already. It's very important to the chief, command staff, and all members of the police department, and all of our officers, quite frankly, are looking forward to getting clinicians on board, because it's just another tool in the toolbox. And as we all know too, there's with mental health issues also come the co-occurring substance use. So the clinicians will also be working closely, obviously, with the community opioid outreach team to tackle those issues as well. So we're not quite there yet with our implementation, but we are really hoping we get the clinicians on board in 2021 and we can present something much better in 2021.
Thank you. Any questions? Questions?
I'm just following up. So Roy Frost had asked about the funding for the advocates model. Marianne, is this, how is the Lowell model? Is it a DOJ BJA funding?
It's BJA. The Department of Mental Health doesn't yet have any funding for a co-response program, but it's definitely the Justice and Mental Health program through BJA. But that being said, Advocates is the training and technical assistance for Massachusetts under the Department of Mental Health. And if departments are able to reach out to advocates to, ask questions, inquire about their program. I have their whole, brochure that kind of outlines their program, the history of their program, and how to replicate their program. So that is one thing. DMH is very interested. We would, once we implement this, the advocates model, we would be the largest city in the state to implement to a T the advocates model.
Thanks.
Anybody else? All right. Thank you.
Thank
And turning finally to a different model, I'm pleased to introduce Sabrina Vogelin and Lena Klein. They're the two social workers in the Cambridge Police Department's clinical support unit. Sabrina's primary focus is on substance use disorder and responding to overdoses, while Elena works with the homeless population and those with mental health disorders. So thank you both for being here.
Thank you for having us. My name is Sabrina. I'm a master's level social worker at the Cambridge Police Department, working on our partner initiative, which is our opiate outreach program, and following up on mental health calls as well. I'm also with my other coworker, Lana Klein. She's going to go over some of clinical support unit in our section that we're part of at the police department.
Hi, my name is Alana Klein. I'm also a LICSW with Cambridge Police Department, and I am going to quickly share my screen just so you can see a breakdown of what our section looks like now. The Cambridge Police Department started about 10 years ago, maybe a little bit longer, in trying to better serve individuals with various vulnerabilities, including mental health issues, issues of substance use, issues with developmental delays, and issues with homelessness, and also particularly youth who were becoming involved in the criminal justice system. So over that period of time, we've built up a pretty substantial program, and I'm going to share my screen now so I can show you guys what it looks like now. All right. So this is sort of a little bit of a confusing flow chart, but this is our family and social justice section. And within that section, there are 3 units. So we have our family justice group, which is a group that includes specially trained officers who work with adults experiencing homelessness, adults experiencing mental health issues, and also elders. In addition, within that unit, we have juvenile detectives who specifically work with youth. We have our clinical support unit, which Sabrina and I are a part of. Also in that unit, our supervisor, Dr. Jamie Barrett, he's a psychologist who works full-time for the department. And we have a strategic partnerships coordinator, Adam Patton, as well as a director of community outreach. We're all non-sworn employees, so meaning none of us are police officers, but that work for the department. And then we also have our family justice group within this section. And so that includes all of our youth resource officers who are in the schools, but also in our youth centers and also in the community, running some youth programs. We have a youth boxing program that I co-run with one of the officers, and we have some other programs as well. And pre-COVID, a ton of different community events geared towards youth. And then our domestic violence unit is also a part of this section as well. And again, involves specially trained officers as well as 2 victim advocates who we work really closely with as well, because I'm sure, as everybody knows, there is a ton of crossover among all the populations that we work with. So I'm gonna turn it back over to Sabrina, and then I think she'll turn it back over to me.
Thanks, Alana. So I'll talk a little bit about our partner initiative that we work on at the department. I am the master's level social worker at the department that works on this program. So the response typically pre-COVID looked a little bit different, but we've had to modify it a little bit since then. Initially, our response would be either to the scene or to the hospital of the overdose, where the patient was transported, and we would talk with the individual and provide them with resources if they were interested in doing that. We also utilized harm reduction models and methods and provided access to that information as well. Typically, it was difficult engaging with individuals at that time. It's very uncomfortable after you've experienced an overdose. And so we were finding that follow-up with them within 24 to 48 hours was the best method. So that entails following up by phone if they have phone number. Our officers are constantly in the community and know a lot of our individuals who struggle with these things and can relay information. There's an outreach team that Alana can probably talk about more that goes out on Wednesdays, every Wednesday, to do some outreach as well. Through the initiative, we also work with family members of individuals who are struggling, and if they're interested in getting access to treatment for their loved one, we will help them with that. And also, sometimes within the department, we have access to a lot more information than providers do, and so sometimes we could see someone overdosing 2 or 3 times in a day within 24 hours, and so then you kind of work with their providers and try to figure out the best treatment for them, or if a Section 35 might be appropriate. But that's a pretty brief overview of all the things that we do for that initiative. We also work on mental health calls as well, which Alana can talk a little bit more about.
All right, so I guess just on a practical level, in terms of thinking about what we do every day, it's really, really diverse. We do a lot of follow-up calls to individuals who have had a mental health crisis where there's been a police response. We try to do follow-up calls to every single individual who's had a police response for suicidal ideation or a suicide attempt. And the goal of that call is to check in, see how they're doing, and ensure that they're connected to services. And sometimes people are, but a lot of times we find that officers may respond, they may bring someone to the hospital, and then that person may be discharged very quickly and be sort of in the same life situation that they were in before the crisis, which is really, really sad to see and very frustrating. So we work very hard, and I should mention we also do have 2 social work interns who work with us, but we work really hard to ensure that people are connected with services that are ongoing, so that hopefully we're minimizing the risk that they're going to have another crisis in the future that is going to require police response. We've had a hugely positive response to that. I know Sabrina has as well. We also do follow-ups with family members in certain situations, especially if the person in crisis was a juvenile. And at times we also are in close communication with people's providers. So particularly for individuals who have intensive services through DMH and have, community teams, we may be in close communication with those teams and making sure that if a if a client has a crisis, that their team is alerted right away so that they can respond and they're aware of what's going on with the individual. And again, we've had a really positive response with that. In addition, we're part of a multidisciplinary homeless outreach team because as those of you who are familiar with Cambridge know, we have a very substantial population of homeless individuals here. So every Wednesday morning, we meet as a group, and this includes homeless providers throughout the city. I think there's about 30 people right now who are involved from many different agencies, including people from the hospital, the shelters, the other outreach teams, et cetera. And we just go out on foot, sometimes accompanied by homeless outreach officers, sometimes not, and check in on individuals that we're concerned about. Sorry, I got distracted by something in the chat. And we, particularly, as the weather gets colder, we have specific individuals who we are focused on checking on to make sure that they're all right. And again, the overarching goal of that is to try to connect people with housing, shelter, or to meet other needs that they have so that ideally they are not living outside permanently and that they're not going to be in situations where, that could cause crisis because they have because their lives involve so much stress. Obviously, as we know, living outside is extraordinarily stressful and can really, really make it difficult for people who may already have pre-existing mental health or substance use issues. In addition to that, we work very closely with our two specialty courts, our recovery session, which is our mental health court, and our Cambridge Community Court, which was just renamed yesterday. That was formerly our homeless session. And we participate in the staffing meetings that happen before those sessions which are really about, again, trying to connect individuals with services, help them to leave the criminal justice system or minimize their involvement as much as we possibly can in the criminal justice system. And those have been great partnerships as well. Along with that, we have a youth diversion program, which is, I would say, our official diversion program, although unofficially we are diverting a ton of adults every day. But the youth diversion program is called Safety Net, and it's been incredibly successful. Again, it's a collaboration of providers throughout the city who work with youth, and they are able to refer youth to this program, and they can be discussed within the group, obviously, after releases are signed, and plans are developed to try to help intervene with the youth that are, I would say, experiencing the most challenges behaviorally in the community. And I know, again, that's been a really big success. And I know my supervisor could quote the numbers much better than I can, but I think we've reduced the juvenile arrests per year down to below 10. I think, really low, which is incredible because, Cambridge is a city of 100,000 people. So we're really, our goal is to arrest 0 youth every year. And we're getting closer and closer to that goal. Obviously, there are certain situations where there are mandatory arrests in our state where officers don't have discretion to make the decision not to arrest. But for the most part, we really try to take other approaches to that. We also, our officers go through a lot of the training that was mentioned by other presenters. So CIT and mental health first aid. And in addition, we have a trauma-informed law enforcement training, which is an intensive 3-day training specifically geared towards helping law enforcement work with survivors of sexual assault, which is incredible. I participated a couple of years ago, and it's an amazing training organized by our victim advocates. And we also recently had a huge number of officers participate in implicit bias training that was run by somebody affiliated with Harvard, which was also really an incredible training. And Sabrina and I were there too. It was awesome, and it was a cool thing to see, and it was a nice thing to be able to do with such a huge group of officers. So Sabrina, I'm gonna turn it back to you because I'm sure there's something you're getting.
That's okay. I just wanted to emphasize the relationship between our clinical staff and the officers, and how it's imperative that we are working in collaboration with each other. I know, as I previously worked at a men's recovery home It was a 6 to 8 month program. You wouldn't necessarily know, where your clients were going during the day or what was going on. You see them maybe once a week. And then, you're not quite sure what's going on during that other time. I think what's special about our officers, at least in most of the squares, is that they know these individuals so well, and they're able to identify when someone's even starting to decompensate. So even before there's an incident, they're able to call either Alana or I and say, hey, this person seems to be struggling, they're not at baseline anymore, and they're concerned about their well-being. So Alana and I can follow up with either their providers so that they can check in with them, or Alana or I can follow up with them as well. So that's a lot of the, like Alana said, more of a prevention side of things, to decrease negative interactions or possibly violent situations with individuals from a police response. So.
Yeah, and I don't think we mentioned this, but our funding is, entirely through the police department. So we're directly employed by the department. So we're very fortunate to have a city that is really committed to this, which is great. And I don't know if we've used up all our time. I know we've talked a lot. I guess just I'll very quickly mention the other two members of our non-sworn staff, other than our supervisor. So our director of community outreach, Keston Green, he does a ton of work around organizing programs, connecting with different community members, and he also answers a phone line and a general email address with inquiries from everything under the sun, from community members who have questions about parking tickets, to an individual who's homeless that they saw who looked like they were in bad shape in a certain location. And so Keston then can pass that information along to the appropriate person, which is usually Sabrina or I or one of our specialty officers to follow up. And then Adam Patton, who is our strategic partnerships coordinator, organizes our quarterly stakeholders meeting, which I think is similar to something that was already discussed, but we have a stakeholders meeting where we invite just different providers and stakeholders within the community. And I think we've over 100 people were attending those prior to COVID again, obviously. So that's really amazing resource that we have as well.
Alana, I just want to back up for 1 second and just really call people's attention to one thing you said. We hear, and in the context of many things that have been going on over the last year or so, about the whole idea of how many times kids get into a bad situation once they fall into the criminal justice system. And it's, often referred to as that school to prison pipeline. And, again, this is a testament. It's happening in so many of our cities, but to have a city where you have over 100,000 people, Cambridge also tends to skew as a young city, and to have fewer than 10 kids arrested over a year is really pretty remarkable. That doesn't mean that there aren't incidents happening, and it doesn't mean that kids aren't finding themselves in interaction with the police department, but we're able to get to a place where that's not resulting in them appearing in criminal court. And that's, I think, again, as I said at the beginning, there's so many bad things happening and we're caught up in that. To really just take a look at who's here today and the work that's getting done is pretty amazing. So thank you.
Thank you.
Any questions? No? All right. Thank you. Thank you both.
Thank you.
Thank you.
You may remember we at, I guess 2 meetings ago, we're talking about an event on October 19th with the Mystic Valley Behavioral Health Coalition that was held with Melrose Wakefield Health System. And it was really a great online event, and over 100 people turned out. And I think if we think about going into the holiday week and the December holidays and all the choices, Dr. Tina Runyon gave a great presentation. focus really not only on helping yourself, but on thinking about the struggles that everybody else is going through. And probably the catchphrase being, which is so hard for us to say many times, these are hard choices, and I'm sure you did the very best coming to whatever that decision is, whether you're having Thanksgiving, not having Thanksgiving, sending the kids to school, whatever you're doing. But it was a great event, and we had so many people able to join, and even seniors who might have been a little hesitant about navigating Zoom were able to get on the phone and join us. And I know Eileen Dern is here, and Eileen really worked tirelessly on this project. So I'm going to give you a couple of minutes, Eileen, to just talk about the event and sort of the feedback.
Yes, absolutely. Thank you, DA Ryan. It was a very exciting presentation because it did involve so many people in the community. We started this regional public health coalition last December, and the goal of it was really to make sure that there was some consistent education in the community, places for people to call, and to really embrace a collaboration of the different local providers of behavioral health. We found that we communicated, but not always in a way that was helpful to everyone. And so this coalition has been meeting to let us really find that way to communicate together for the best impact on our community. And we're gradually growing the coalition and inviting new members to join us. So as District Attorney was speaking about, we had our first event in October, and we hired a professor out of UMass Medical, Christine Runyon, and her expertise is in working with especially providers that have worked through trauma. And we talked a lot about how just simple kindness was incredible in being able to navigate this pandemic. Lots of tips and tools. We are in the process of having that video made into a few shorter PSAs so that people can post that on their website with a link to the longer presentation. And I know Megan Kelly from the District Attorney's Office, Nora Mann, myself, and Rob Bronya from Melrose Wakefield will be doing that. The coalition involves people who are here today, such as Jason Stone from AdCare Hospital, and really trying to find those ways to help our community moving forward. So over the next few weeks, we've decided that we'll move back to more of a monthly schedule for the bigger coalition. We'll have some task forces working on particular topics, and we're hoping that some of our member organizations will work with us on writing tips and tools that we can post out to the local papers on everything from depression and anxiety to elder isolation, messages for teens, just as you were talking about the high suicide rate and the things we're most concerned about. Certainly substance use. We see a lot of alcohol issues in our community here. And we're hoping that as we're coming together in a few weeks, we're going to be seeing the first soft opening of our recovery center here in Malden, right above my office, which it's the Bridge Recovery Center run by the Gavin Foundation. And we've already talked about some of the ways in which we can work together. The nice thing about this recovery center is they will be doing both 12-step and medication-assisted treatment programs for people in the community. So moving forward, if you have any interest in joining the Mystic Valley Behavioral Health Coalition, we would love to have you as part of our membership. And as I said, we'll be doing some work over the next few weeks to really support the community. And then as we move forward, a couple of other things important to mention is Melrose Wakefield Hospital has an open RFP on our website, and this is to fund organizations in our communities to serve the behavioral health needs of elders, children in school age K-8, and or to work on stigma. And this will be a 4-year RFP, and it's part of the new ambulatory surgical center that's being built at Lawrence Memorial Hospital. So applications are open until the end of this month. So the 30th of November is the last day to submit, but they're nice grants. I think lots of opportunity for people to look into that if you haven't already. And we really want to encourage this continuing collaboration, communication. We're so lucky to have the district attorney working with us, NAMI. We have folks from the Mystic Valley Public Health Coalition. We have other people working with us from many other organizations such as Elliott and Wayside in Medford, and then many of our police, fire, and other local first responders. So thank you so much for this time this morning.
Thank you, Eileen. Anybody else have updates or things they want to raise? Very quiet this morning. All right, so next month, excuse me, is giving you a little preview, and we'll be sending out the dates, but we will have an organization with us called Shatterproof. This is pretty interesting. They're going to tell us about a new web interface, which is called Atlas, that does two things using 8 evidence-based quality measures. It allows users, whether you're a patient, a family, a provider, or a first responder, to make an assessment about the appropriate level of care for someone and the quality of the care that's being provided by various programs. And again, it's with an evidence-based factor. So you can look across your communities, you can help families. Often people are struggling with getting somebody to a treatment and they don't know what kind of treatment they should go to, or there's a myriad of places and they might be making an assessment just based on how a place looks or what kind of insurance or whatever, without really knowing how good the treatment is. So this will really address both of those. So we will get out the information shortly about the next date. And in the meantime, please stay safe and have a very safe, socially distant Thanksgiving. So thank you all. Thank you to everybody.
Thank you.
Thanks, Marion. Thanks all.
Thank you. Have a good day.